morning again. We had two wonderful talks, three wonderful talks actually from prominent rhinologists, and we'll just try to go over some of the techniques to control bleeding during surgery. We all know that if you actually fail to prepare for surgery, you're actually preparing to fail. And this is what usually happens if you don't actually control bleeding adequately. Disasters can actually happen. And this is a case that actually was referred to me from someone. Regular CRS without polyps. And what happened during surgery was disastrous. And the skull base was gone. He actually ended up with a large encephalocele. And when I interviewed the actual surgeon, he said, what he told me that he actually failed to control the bleeding. He couldn't see. So at that point, you should actually stop and not continue with the surgery. And that's the critical point here. If you don't control bleeding, you should not be performing the surgery itself. And we'll just go over some of the strategies to control bleeding during FESS, starting preoperatively and intraoperatively as well. So the moment that you actually start to book a patient, what do you think about preoperatively? Some of the patients that we have multiple comorbidities and are on anticoagulants, and this is where you actually think about discontinuing some of them. When you discontinue these, and this was seen, Dr. Cassiano actually did a study on this and his group. When you discontinue these, you will actually have good results in terms of controlling bleeding. However, obviously, if you don't actually stop them, then the bleeding will actually be tremendous. Baby aspirin, sometimes I don't discontinue, but however, all the other ones, you should always discontinue it, especially if you actually have extended operations. If you have a minimally invasive, something a little small, you might actually, polypectomy for example, you might actually go away with some small little doses of certain anticoagulants, but your goal is to stop all of them. So that's one of the things. The other thing that you have to not underestimate is herbal medications that we in the Arab world have a lot of, and a lot of our patients are on it without you knowing. So I usually have it in my instruction sheets because I always forget to ask them about it, always forget to actually tell them to stop them at least 2 weeks before the surgery itself. Even other things like fish oils and vitamin E can actually increase. We don't have studies about this. However, it can increase the possibility of bleeding during surgery. So these are some of the things you should probably stop prior to the surgery itself. And we know that whenever we decrease the inflammation, the vascularity of the sinuses will actually decrease, and hence the bleeding will also decrease as well. And some of the measures to decrease that inflammation would be either topical steroids, systemic steroids, or possibly preoperative antibiotics. And we'll go over some of these things. And a simple thing that we might consider, and it was actually showed a significant difference, was starting local steroids prior to the surgery itself. The study actually did a randomized controlled trial on Metazone, starting 4 weeks prior to the surgery itself, 2 sprays, BID, and actually led to a significant improvement in the visual field scores, so how much bleeding you see during the surgery itself, as well as the total blood loss and the operative time. So it actually had a significant impact. Although a small little thing that you can actually start prior to the surgery itself, it can lead to a significant impact on your patients with and without polyps. So without polyp patients, if you book them, how about starting oral steroids, systemic steroids on them? Well, in this study, it wasn't really a big study, but we usually don't give oral steroids to non-polyp patients, and this study also showed that it didn't really improve that much in terms of bleeding. So don't recommend using oral steroids for non-polyp patients, either for medication or even for preoperative optimization. How about with steroids? Well, there are multiple studies about this, and these are some of the studies that were published over the last 20 years or so. And most of them, as you can see, have shown a better visual field, operative time, or total blood loss. Degree of difficulty as well was actually less when preoperative steroids, oral steroids were used. However, you have to also consider the possibility of complications, the contraindications of using them in these patients as well have to be considered. So the problem here, and you can actually see it as well, they don't actually agree in terms of the dosage. And so some of them actually use a 0.5 milligram per kg, some of them use 1 milligram per kg, and some actually just use a single dose of 30 milligrams or so, 5 even to 2 weeks prior to the surgery itself, in a tapered or in a higher dose even prior to the surgery itself. So they don't actually agree with the amount or the dose or the course of it. However, they have shown good results. So this systemic review as well was done in meta-analysis and also agreed with that, favoring use of steroids in polyp patients, oral steroids prior to the surgery itself, in terms of intraoperative bleeding, as you can see here, visibility of the surgical field, as well as the operative time. So it does have a significant impact. In research, we sometimes do not use oral steroids just not to affect the actual tissue itself. So sometimes we withhold the use of that, or if you actually have any complications of use or contraindications of use, you have to consider that as well in some of the diabetic patients, the glaucoma patients, and the osteoporosis patients. So you have to consider that. Antibiotics, we do not have any evidence for that, and a lot of people use them. However, no evidence is actually supporting its use in decreasing blood loss during surgery itself or optimizing its treatment. However, the possibility of using in some of the patients when you swab them, especially if they have pus purulence prior to the surgery itself, you can swab them, possibly stop them on oral antibiotics. In some of the cases, it might help. We don't have any evidence supporting that use currently. So just to summarize, in non-polyp patients, possibly local steroids would be enough. In polyp patients, local steroids doesn't harm them, and you might consider oral steroids in some of the cases, especially in the asthmatic patients as well, just to control their chest as well as their sinuses. And dose-wise, we don't actually, there's no agreement in literature. You can go between 0.5 and 1 milligrams per kg, not to extend anything beyond 60 milligrams or so, just to go beyond the possibility of complications. And 5 to 7 days prior to the surgery should be enough prior to the surgery itself. The role of budesonide rinses currently is still unknown as well, and you can definitely stop them. They won't harm the patient, and they possibly can improve the bleeding as well. There's no known role for antibiotics currently, but it might be considered. So those are the pre-operative measures. What about the intra-operative measures that you can actually do? And most of us, and I think all of us, agree on using vasoconstrictors during the surgery itself. Topical vasoconstrictors have been used for so long. Adrenaline, xylometazoline, cocaine, and others, ephedrine as well in the past. And systematic review has been published a few years ago about this as well, just getting all the publications on this, and a majority of rhinologists agree on using them. I use 0.05 xylometazoline, especially in pediatric patients, if I have them. In the adult patients, I use 0.1 xylometazoline sprays prior to the surgery itself. It does help, so half an hour or so prior to surgery in the holding area. They just spray a few sprays on each side. And intraoperatively, after they're intubated, I use pledgets with xylometazoline itself. It does not have a significant impact on systemic. It does not have that much systemic issues compared to adrenaline. However, if I have significant bleeding, I use 1 in 1,000 adrenaline or 1 in 2,000 as well. So there shouldn't be any systemic issues using that. However, you have to be cautious about using that in some of the cardiac patients that we deal with, some cases. Combining them as well is not really recommended. It doesn't really add that much, and it might actually lead to more systemic issues later on. So that's the topical ones. What about the injectable ones? Dr. Wormold presented a great talk about injectables as well as the role of Tiva prior to the surgery in the last FES course a few days ago. And we talk about the lateral nasal wall, as you can see, as well as the pterygopalatine fossa through the greater palatine foramen blocks. So both are injectables, and both can be used and have been used in the past. And there are multiple studies about them. So if we start with the pterygopalatine fossa injection, Dr. Wormold presented or published this in 2005, combining both the pterygopalatine fossa along with the lateral nasal wall in one side versus lateral nasal wall on the other side. And he has found a good response in the Bozart scores in between the favoring use of pterygopalatine fossa injection. This was repeated in another study in Montreal in 2014. They didn't really find a significant difference in terms of the blood loss as well as the visual field or the operative time. Dr. Cassiano's group and Dr. Eloy in 2014 as well have repeated that in different patients, and they also did not find a difference in estimated blood loss. They did not concentrate on Bozart scores. So there is some controversy about using that. In terms of the lateral nasal wall injection, there hasn't been that much published, unfortunately, in terms of the optimizing the field itself. In 2008, Dr. Witterich's group in Toronto published this, and they found that some of them have higher mean arterial blood pressures with using it, and that's the problem when you actually use adrenaline, injecting it in the lateral nasal wall or anywhere in the sinus cavity. It might actually lead to a possibly higher mean arterial blood pressure, which might actually be more difficult for the anesthesiologist to control the blood pressure at that point. So they didn't find a difference in estimated blood loss. However, they found some improvement in the visual field scores. Dr. Gervais' group in 2009 have repeated that with a much larger group, and they haven't really found a significant difference, neither in blood loss or in operative time. They did not do the visual field scores, unfortunately, but they also found a higher mean arterial blood pressure. If you notice as well that they used a 1 in 200,000 epinephrine, and that was because they actually started with 1 in 100,000 and had one of the cases with an acute MI. It was a cardiac patient, unfortunately, but still it can lead to, it's very rare, but it can lead to possible side effects systemically. So there's no real clear added benefit of using injectables if you're actually using topical vasoconstrictors. And I think topical vasoconstrictors are safer and should be enough in the majority of cases. However, some cases, epistaxis patients, tumor cases, you might actually have the added benefit of injectable vasoconstrictors at that point. Patient positioning inside the operating room is another important thing, especially for bleeding as well. And we talk about reverse Trendelenburg position at that point. And this, what happens when you actually have the head elevated is that it reduces the mean arterial blood pressure in the elevated regions as well as the central venous pressures as well. So the cerebral perfusion is preserved up to 30 degrees or so, and that's critical. So if you go above 30 degrees, you can actually lead to significant complications in terms of cerebral perfusion, so you have to be careful about that. The mucosal blood flow as well was shown to be less in the reverse Trendelenburg position in the inferior turbinates in some studies, so it does have a significant impact. And this was studied in the St. Paul's Sinus Center and randomized 3 angles just to see which angle is actually the best in terms of the optimization of the field, in terms of visual field scores as well as the operative time and the bleeding. And what you see here is a clinometer. So it's in the first picture on the right side. The clinometer is a small little adapter, or you can actually have it in your phone. It just tells you how much of a degree that the patient is, and we basically covered the patient and randomized them and blinded the surgeon on the degree. And 20 degrees was actually the best. If you go beyond that, it might actually decrease the cerebral perfusion, but 20 degrees was actually the best in terms of surgical field of view scores and the lowest total blood loss. So usually when I do it in the operating room, using the clinometer helps. Most of the time we actually go 10 degrees or so. If you actually use a clinometer, you see that it's actually much more than what you anticipate, so you underestimate it visually. So clinometer actually helps, especially in your phone. There are apps for that. So in terms of something that I sometimes use as well is flushing. A lot of flushing actually leads to much less bleeding. You get this guy with allergic fungal sinusitis, you flush all the fungal debris out, and actually helps in decreasing the amount of bleeding during the surgery itself. What about if we upgrade that? What about if we actually heat up the saline itself? This is what we studied in another study published a few years ago. We went back to animal studies to know what degree actually helps. And this was published a long time ago, probably 20 years or so ago. 24 rabbits exposed to hot water irrigation. And this is a long time ago. A lot of people actually use hot water irrigation for multiple things. gynecology, for example, and even neurosurgery uses them a lot. And what they found is that anything below 48 degrees didn't really have a significant effect on the bleeding, as well as the mucosa itself. Anything between 48 and 50 approximately had edema of the mucosa, which actually cascaded or accelerated the clotting cascade and led to less bleeding. Anything beyond 52 actually led to necrosis of the epithelia. So it's hitting that point of 48 or 49 is actually important to control the bleeding. This is what we did in a randomized study as well, blinding the surgeon with using a suctioning with a shaver, and not seeing as you can see in the second picture, blinding the surgeon from the actual degrees. We go around 48 to 49 degrees, and we flushed the sinuses every 15 to 20 minutes with 20 cc's of 48 degrees saline. And that actually led to a significant impact on total blood loss, and that's the main thing that we found. The Bozard scores didn't really change that much. The blood loss per minute, of course, also changed significantly as well. However, if we plotted that over time, we found that anything beyond 2 hours actually had much more impact on Bozard scores, as you can see here. So the regular saline group, the regular temperature, had a much higher Bozard scores compared to the hot saline group beyond 2 hours, and that was significantly, statistically significant as well as clinically significant. And what we think is possibly just related to the vasodilation that happens later on during the surgery, and the possibility of where that helps, where the hot saline actually helps at that point. So our conclusion was we use it, especially in advanced cases where you suspect that we're actually going beyond 2 hours or so, or even in tumor cases as well. It does help in using that. However, you have to have the warmer beside you, because just because using a warmer, the wall warmers will not really help that much. It actually goes down to 40 or even 35 quickly if it actually comes out, especially if it's on the table of the nurse. So it does help in some of the cases. Anesthesia technique, there's a lot about this, and we'll just spend a few minutes on it. Controlled hypotension is what we usually talk about, and it's defined as having the mean arterial blood pressure between 60 and 65 or so. However, in some of the patients where they're hypertensive, you can't really go to that range. It actually leads to hypotension that's not controlled at that point. And the anesthesiologist defined it as a 15 to 20% decrease in the baseline, from the baseline mean arterial blood pressure at that point. So having that decrease can lead to possibly decrease in bleeding. And whenever we talk about controlled hypertension, we talk about Tiva. So Tiva is basically total intravenous anesthesia using propofol and remifentanil. And a recent systematic review, multiple ones have been published. This is one of them in Rhinology just a few months ago, included 12 randomized controlled trials with 560 patients. And they found that Tiva was superior to inhalation anesthetic using sevoflurane, desflurane, that most of the anesthesiologists use. It is superior in terms of the visibility of surgical field, as well as the estimated blood loss. The operative time was also seen to be more superior in that, especially if they use remifentanil instead of fentanyl. But you have to be cautious about interpreting these results. Due to the heterogeneous nature of these RCTs, they've used multiple doses, different doses of analgesics, multiple things that are different between them. So you have to be cautious about that. However, we agree that, or the majority of them agree at least, that in the majority of the advanced cases, this is where it actually helps. And that was also published in IFAR a few months ago as well, or a year ago. If you actually can achieve that with a different technique, it does also have the same results. So if you combine remifentanil with an inhalation anesthetic, which is much cheaper than propofol, compared to remifentanil with propofol, which is Tiva, you can achieve controlled hypotension as well. And that has been shown in one of those studies that I've mentioned, and they're equal in terms of the visibility of surgical field. So you can achieve controlled hypertension with remifentanil and inhalation anesthetic without propofol. So it's something that you can achieve, and it's much cheaper. Is there something that's better than Tiva? Well, if you actually combine, Dr. Wormold mentioned using clonidine. He likes using a lot of clonidine in his practice. And clonidine is an alpha-2 agonist that actually has a sedative as well as a effect on blood pressure as well. And this study actually used Tiva as well with Presidex. Presidex is also an alpha-2 agonist, is a newer one, much more expensive as well. And it does have a great effect with a shorter half-life. So they combined both Tiva with Presidex, and that actually led to even less bleeding. So this is called, I would call this super Tiva at that point. So it's even higher than Tiva itself. So it might be considered in some of the advanced cases, but you have to consider as well the cost of using it as well, and the applicability as well as the availability within the OR itself. So we always look at the blood pressure, and this is something, but you see this field and you think, well, the blood pressure is pretty good, the map is around 56. We also have to look at the heart rate. Whenever they go down with inhalational anesthetics, especially inhalational anesthetics, so we go up on it, it goes down on the blood pressure, but the heart rate goes up. A reflex tachycardia happens at that point, and you have to be careful about that. So you have to also have the heart rate around 60 or so to achieve a better result in terms of bleeding. And to achieve that, you can actually use, Dr. Wormald published a few papers on this using esmolol, and you can see that whenever the heart rate goes up, the Bozart scores, or the visibility of surgical field of view scores, also go up. So you have to consider that in looking at the patient and looking at those numbers, and you have to control it. So good communication with the anesthesiologist is key during these cases. Controlled hypotension can be achieved with remifentanil and inhalation anesthetic, but Tiva would be possibly better along with Presidex, with or without Presidex in some of the advanced cases. And never forget the heart rate. We always forget the heart rate whenever we consider the blood pressure. So another thing that, we always have these cases that bleeds no matter what. Some of the instruments that we have actually have suction, and that's something that helps, especially if you're using one hand compared to two hands, as Dr. Dim Simon. He's very lucky to have an assistant with him. If you have two hands, then at that point it doesn't really matter. However, if you have only one hand to spare with instruments, then endoscopic instruments, bipolars, as well as curettes can help in these cases, especially in some of the tumor cases. So those are some of the things that you can achieve to control the bleeding during FES. Other things that might be considered as well is using LLMAs. A lot of anesthesiologists or even rhinologists use it. Dr. Wormald uses it, likes using it. But some of the anesthesiologists don't like using it if it's prolonged, especially just because of the control on the airway as well is much less compared to endotracheal tube. However, the amount of anesthesia is much less. Hence, the control of the blood pressure and other things would be much less at that point. Use of tranexamic acid has been published multiple times and has been shown to have a good effect on bleeding as well intraoperatively without any significant impacts as DVTs and others. And you can check the literature about that. Topical hemostatics have been used in some of the tumor cases. However, you have to consider that some of them actually attach themselves to the mucosa, causing possibly granulation tissue and other things later on in terms of healing. So you have to consider that as well. A meticulous surgical technique without removing a lot of mucosa actually helps a lot in decreasing bleeding. Whenever you remove the mucosa and rip it out, it actually leads to much more bleeding compared to a mucosal preserving technique. So a lot of that will hopefully help in achieving a successful operation, especially when you're done with the sphenoethmoidectomy going up to the frontal sinus. Right there you have to have a good field, and hopefully you have some of the key elements that might control bleeding during surgery. And you can also take a picture of this. We published a review article about all these things recently, just last year. And you can get the full text from this, and it's a good reference for that subject. I also invite you to come to our endoscopic cell-based dissection course. This will be just in a few weeks in King Saudi Arabia and Riyadh, February 1 and 2, and it's combined neurosurgery as well as rhinology course. There are vacant observer slots available as well, and you can contact the email for that. And I would like to thank you all for listening.